It's a pleasure
Good morning,
to invite
ladies and
Dr.
gentlemen.
Dinesh Talwar. Yeah.
We now come to subfoveal CNVMs, including age-related macular degeneration causing CNVM. This is my disclaimer and financial disclosure. See, exudative CNVMs, subfoveal CNVMs, not a single disease, not even in AMD. Even in AMD, you have the predominantly classic, the minimally classic, the occult. The occult itself has three different varieties: the late leakage from an unknown source, fibrovascular RPE detachments, and serous RPE detachments. In addition to that, you have myopic CNVMs and inflammatory CNVMs, which can behave differently. Now, the good thing was that the Marina and Anchor studies showed us that monthly regime of treatment with ranibizumab is very effective not only in preserving vision, but in improving vision in these cases. However, this is an extremely intensive way of treating the patients and is exhausting for both the patient and the doctor. Fortunately for us, today we have a large therapeutic armamentarium, including ranibizumab, bevacizumab, aflibercept, brolucizumab, and faricimab. And we also have multiple treatment protocols for exudative AMD and other types of CNVM, including in addition to the monthly injections, you could have quarterly fixed injections or PRN or treat and extend. Over the last few years, treat and extend have become an increasingly popular approach because of its safety. However, how you treat a patient also depends on what kind of CNVM you have. Even today, for me, for type 2 CNVMs, the treatment of choice is not aflibercept, but ranibizumab. For type 1 CNVMs, I believe aflibercept is significantly better than ranibizumab, and that's the way I start. Faricimab, I use in patients who don't respond to aflibercept, and it can help you to extend the treatment interval by 2 to 4 weeks in those patients who are recalcitrant to treatment. And for me, brolucizumab, though it's more effective in drying fluid, but because of its lesser safety and significant lesser safety, it is my third line option. Now, the treat and extend regimes are more proactive. It means more number of injections. So be careful. In our setup, it means a patient may have to shell out a lot more, but I believe is the safest option for one-eyed individuals. It's also a very good option for patients who are stable but not dry. And now the world is coming around to accept this, that patients who are stable and not dry need to be treated with a treat and extend and not keep on giving them monthly injections. Monitoring, but the difference is, I believe it's important to monitor every 4 weeks, even if the treatment interval becomes greater. So you monitor every 4 weeks, treat them with a treat and extend regime. The wait and extend is actually a way of monitoring and then extending in patients who become dry. And when they become dry, you can extend the interval between follow-ups slowly up to almost 3 months. But this is only after you have a lesion which is dry for 6 months or so. And this is possibly the best option for two-eyed patients in whom the lesion is dry. Now, how much can we increase the intervals between treatments? This depends on the drug you're using. The fluid study showed us that with ranibizumab, the average interval you can extend to around 7 weeks. The Altair study showed us that with aflibercept, you can do a treat and extend of up to 12 weeks in at least 60% of patients, and up to 40% of these patients can go up to 16-week intervals for the injection. That means 3 to 4 injections per year. With faricimab, you can extend to more than 12 weeks in 80% and to 16 weeks in 60%. So it's higher than that, but it's a much more expensive drug. And brolucizumab also can reach 12 weekly injections in over 50% of patients. As of today, aflibercept is my workhorse for patients with type 1 CNVM or type 2 CNVM who have multiple recurrences. Now, what is the algorithm I follow for management? All types of CNVM, you give them the 3 loading doses, month 0, 1, and 2, assess the response at month 3, and see whether the vision is stable or improved and is the lesion dry. Now, if the lesion is dry, you have 2 options. You can either go to a treat and extend mode and increase the intervals slowly till you come up to 12 weeks with ranibizumab or 16 weeks with faricimab or with aflibercept. Or you can put the patient on PRN treatment. Now except in myopic CNVMs, where you don't give a loading dose. In myopic CNVMs, you see and stop treatment if 2 consecutive OCTs have an identical morphology. So you gave the first injection, patient improved. Now you give one more injection. If there's no difference between this OCT and the next OCT 1 month later, you can stop. You don't need to give a third loading dose in this situation. Now, so this is a continuation of the same algorithm. So the lesion was dry. One-eyed patients, I would put on a treat and extend regime. The patient is two-eyed. I would prefer to have this patient monitor. We monitor every month for 3 months, and it stays dry for 3 months. You now extend the interval between follow-ups from 4 to 6 weeks, then 8 weeks, then to 10 weeks and 12 weeks. But 12 weekly follow-up continues lifelong in these patients. It will never stop. If a recurrence occurs, the patient gets a PRN treatment, and over a period of the next few months, you gauge how often are you needing this PRN treatment, and then you can put him into a treat and extend regime depending on what you see is the duration which the patient is regularly requiring the treatment. If the PRN treatment is with ranibizumab and it's less, you're giving the injection less than 8 weekly, consider changing to aflibercept. The second group of patients have received 3 injections and they are still not dry. They still have some fluid, but it's stable. Now you continue the monthly injection for the next 3 months. If it dries, follow the algorithm which I just told you previously. If it doesn't dry, this is the stage to now convert to a treat and extend regime, increase the duration between the injections and see whether at 6 weeks the fluid remains stable, then at 8 weeks, then 10 weeks, then 12 weeks. Whatever level it remains stable, you stay there. If recurrence occurs or increase in fluid occurs, you decrease the duration between the injections. Now the important thing is that your initial 3 loading doses, say with aflibercept, which is now my workhorse, is followed by the treat and extend regime in patients who are stable but not dry. And if you can maintain this on greater than 8-week intervals, in 10 weeks, not bad. But if it's not reached, consider faricimab. And if that doesn't work, then only the last option is brolucizumab in only those patients who have both the eyes. I will not give brolucizumab in one-eyed individuals. So this sums up the further algorithm. One-eyed patient, you give treat and extend, you're able to extend beyond 8 weeks, continue with aflibercept. You're not able to extend beyond 8 weeks, go to faricimab. Similarly, stable lesion, not dry, treat and extend aflibercept, you can extend beyond 8 weeks, continue, you can't, go to faricimab. This is a combination of economics and good science. Now, this is just to show you an example. This was a patient who came to me. He had actually had initially brolucizumab, and he was one-eyed, and I said, I'm not going to give you another brolucizumab. When you get the recurrence, I said, I'll try with eccentrics. I tried, it worked for 4 weeks, and after 4 weeks, he got a recurrence. This time I tried aflibercept, and again with aflibercept, after 4 weeks, I got a recurrence, so we gave him faricimab. And with faricimab, there was a resolution. 4 weeks, there was resolution, but by 8 weeks, there was a recurrence. So again, he received a faricimab, and this time, again, resolution occurred, but at 9 weeks, we got a recurrence. So I realized that 8 weeks is probably the most we are able to do. We managed to extend him, again gave the injection. This was again at 8 weeks. And the third time, again, we put him on this and managed to take him to 9 weeks. What I realized was that by converting from aflibercept to faricimab, we were able to go to extend the interval by 4 weeks. This is another patient whom we tried. Eylea was given, did not respond, and finally was shifted to brolucizumab, responded very well. And a second patient whom did not respond so well. This was on Eylea, got a brolucizumab, got a partial response. This is just to let you know, people who think brolucizumab is a panacea for all their ills, it's not. In recalcitrant patients, some 30% respond very well, complete resolution, another 30% show a partial response, and there's also 30% who don't respond. So when to switch? If you're on ranibizumab and you're getting recurrence in less than 7 weeks, switch to aflibercept. If you've got a stable lesion, not dry, and you're needing injections monthly to 6 weekly, again switch to aflibercept. If the patient is on aflibercept and you're needing injections more than once in 8 weekly, again consider a switch to faricimab if the patient can afford it. The same applies if the patient is stable and again you're needing 6 to 7 weekly aflibercept, switch to aflibercept. Brolucizumab I would only do if the patient doesn't improve with faricimab and the patient is two-eyed, and in that case too, I would not repeat brolucizumab in at least once in 8 weeks I will keep. I may 4 weeks later, if there's still fluid, give aflibercept. Now, just for those who say, hey, what the hell, yeah, they're talking about drugs which we can't afford. The good news is long-term studies have shown, and this was a comparison of ranibizumab, aflibercept, and bevacizumab, that ultimately the difference did not come in terms of the injection. It came in terms of the number of injections. So no difference in outcomes regardless of which the drug was, no difference in OCT, but the difference was the more the number of injections, the more the time the injections continued, the better the visual outcome. So don't ever fret. Your patient can't afford faricimab is not the end of the world. He can't afford aflibercept. It's still not the end of the world. We have biosimilars of ranibizumab. Continue on that. And just to show you, this is a study from Switzerland where they gave ranibizumab, and over 7 years, giving injections at 4 to 8 weekly, they were able to maintain better than 20/40/612 vision in 43% of patients. They were able to maintain better than 618 vision in 2/3 of the patients. So the important thing is to continue and not to give up. My basic principle is I have no tolerance for fluid. Saying I tolerate fluid is like the fox saying grapes are sour. Intraretinal fluid, not tolerated at all. Subretinal fluid, tolerated if it's stable, and I can't remove it. Sub-RP fluid, don't run after. It doesn't affect your final outcomes. But any increase on fluid is not tolerated. Ladies and gentlemen, ultimately, aggressive treatment is the key. Monthly follow-ups are essential till the lesion heals, and then 3 monthly is lifelong. Greater the number of injections, the more intensive and longer the follow-up, the better the visual outcome. Initial PRN can be converted to later treat and extend regimes, but you have to have a very high index of suspicion for retreatment, any loss of vision, any new fluid, any macular hemorrhage. Therefore, fundus examination is equally important. And any subjective evidence of fluid, you're following up and you say, no, it's increased, give the injection. Eternal vigil is the price we pay for maintaining vision in patients with CNVM. And with this regime, even with the most economical method, believe me, you will get results comparable to what is quoted in the West. Thank you very much.
Excellent talk, Dr. Dinesh. Does anybody have any quick question? We'll just have a couple of minutes of discussion. I just want to put it in perspective. There was this fluid study which suggested as a shoot-off of the CAT study saying that perhaps you can tolerate subretinal fluid up to 200 microns and it's beneficial. They went as far as saying beneficial. But please remember that the reason in real world we are not able to replicate the impressive results of clinical trials is because all of us tend to tolerate some amount of subretinal fluid. Also, to put in perspective is in the CAT study, there was a clear thing showing that even with monthly injections, only in half the percentage of patients was the maculae completely dry. So there is going to be some amount of fluid. I think what Dr. Dinesh Talwar said is what we should not tolerate is any increase in fluid. And if there is persistent subretinal fluid, do not put the patient on a follow-up, even if you're using treat and extend beyond 3 months. Keep watching them, and if there's any new fluid or loss in vision, we should take care.
Thank you.
So I just...
Anand, after you, we'll have the keynote. So Anand is going to talk about his approach to center involving DME.
So I just wanted to ask, do you use Avastin or biosimilars?
Frankly speaking, I don't use Avastin now because of the problems which we have with cluster endophthalmitis previously. Yes, and also because their product information very clearly says, at least in the Indian one, that is not for eye use. So you are really putting yourself on the line.
Yes.
I use biosimilars. I use ranibizumab as a biosimilar if the patient can't afford it.
Yes.
But of course, if the patient can afford it, for me, for type 2 CNVMs, it's ranibizumab. For type 1 CNVMs, it's aflibercept.
Yes.